Hello, my name is Tao Nguyen, here to present a clinical case of mesenteric mass suspected for sclerosing mesenteritis in the setting of Riedel thyroiditis. Sclerosing mesenteritis is a rare, non-neoplastic inflammatory and fibrotic disease that can affect the integrity of mesenteric vessels and is often associated with various autoimmune conditions, such as Riedel thyroiditis. This poses a diagnostic challenge. We have a 38-year-old female with past medical history of hypertension and uncontrolled hypothyroidism, presented to an outside hospital with weight loss and jaundice. Was diagnosed with mesenteric mass, which was complicated by biliary obstruction requiring a stent. The patient now presented with abdominal pain, hydronephrosis, and a fast-growing goiter with no compressive symptom. On physical exam, the patient had tenderness on right upper quadrant and subborn but diffusely enlarged thyroid gland, no palpable nodule. CRP was elevated to 115. CT abdomen and pelvis demonstrated a mesenteric mass that encased multiple vessel disease, as well as the right ureter, causing hydronephrosis. However, no bowel obstruction. The histology of the mesenteric mass from the biopsy show a lot of fibrous tissue with a lot of plasma cell and lymphocyte. No evidence of lymphoma or IgG4 related disease. Thyroid goiter workup show elevated TSH of 180, free T4 of 0.79, total T3 of 78, positive for TPO more than 1,000. On-cell of the thyroid show an enlarged heterogeneous thyroid without a discrete nodule, consistent with autoimmune thyroiditis. The thyroid FNA at outside hospital interestingly demonstrate a very similar pattern as the mesenteric biopsy shown from previous slide, fibrosis tissue with lymphocyte dominant. Left thyroid core biopsy also showed a similar pattern again, no evidence of carcinoma, lymphoma, IgG4 related disease. The absence of Hurdle cells makes Hashimoto thyroiditis unlikely. Further workup show elevated IgG level, but IgG1 and IgG4 were within normal limit. Patient had proteinuria, but refused a renal biopsy. Infectious workup, including fungal and AFP stain, histoplasmosis antigen, and TB, were all negative. Flow cytometry showed no signs of lymphoma. This patient most likely has SM for various reasons. First, the patient demonstrated a common presenting feature: abdominal pain, weight loss, elevated CRP, present in 80% of SM cases. Mass effects by SM were shown by the obstruction in common bile duct and the right ureter, requiring stent and nephrostomy. Third, histology support SM and makes other differential unlikely. The negative flow cytometry, the presence of sclerosis and absence of spindle cells, the absence of bowel lesion involvement. As previously mentioned, SM is associated with autoimmune condition, particularly Riedel thyroiditis. The timing of the thyroid enlargement and the diagnosis of mesenteric mass, as well as the similarity in histology, fibrosis with lymphocyte predominance, support this association. The thyroid goiter in this case is most likely Riedel thyroiditis. Therefore, the patient was treated with high-dose steroid. Further follow-up is needed to confirm the diagnosis, evaluate the treatment response to steroid, and explore the association between sclerosing mesenteritis and Riedel thyroiditis. Thank you so much for listening.